Positioning and Mobility of a Burn Patient, written by Rebecca Coffey and Andrea Bigley at The Ohio State University, presented by Andrea Bigley. The objectives for this presentation is to understand the proper positioning of the burn extremity, some of the benefits of early mobility, edema management techniques, and active and passive range of motion. There's some particular goals of positioning that you need to keep in mind when we're discussing a burn extremity. We, A, want to reduce the swelling, obviously keep the function of the extremity, and prevent contractures from forming and any deformities that might occur. The last thing that we're concerned with is preventing tissue destruction. Edema is one of the biggest offenders in a burn injury. What happens in a burn injury is that you get the initial swelling to the area, and that's part of the inflammatory process. Those inflammatory mediators cause swelling and a capillary leak into the tissue. And so the edema then can impair the circulation of the extremity to the skin as well as the vasculature. It can also increase pain. What we want to do is elevate that affected extremity higher than the level of the heart. If it's a head, we could actually elevate the head to reduce the swelling to that area. Some of the positioning techniques that you might consider are using pillows, rolled blankets, towels, foam wedges, and other positioning devices available to you in your clinical area. The idea behind the positioning devices is just to help us get the patient in the right position to stay there for a period of time to reduce the swelling. One thing you might do is reach out to your PT and OT departments to help develop a positioning schedule. They might even offer some splints or other positioning devices that you might not have readily available. Some splints that could be used are prefab, even custom-made splints per the therapy recommendations. Particular areas of concern in the head and neck. The neck, if you have a burn in the neck area, if you have contracture formations that occur in that neck as a late effect of the burn, you could impair the airway, impair mobility, and the patient might have more problems with the movement of their neck. What we want to do is maintain their neck in a neutral or slight extension to allow for the proper airway alignment. So we do that by not putting a pillow behind the head and using a towel roll behind the upper shoulders to help extend the neck to get that airway open. A mouth is the other area where we can get constriction from contractures and the mouth opening, so the patient may not be able to open their mouth very well. A couple of things that you can do to prevent that from occurring is to moisturize the lips and then encourage oral exercises so that you get a really good stretch to the mouth, especially around the edges of the mouth. Ears are another concern on the head. They are not as vascular as some of the other tissues in the body. They're slower to heal, and they get prone to pressure sores. So we don't want to use any pillows when patients have burned ears. You also want to think about things like oxygen tubing or NG tube securement devices that might be secured around the ears. Those can cause further damage. Try to use some other securement devices for those if possible. Torso positioning. On the torso, we're worried about the axilla and the shoulders. If they have burns in those areas, we want to make sure that those are at a 90-degree position. That gives a full stretch to that area so that you can maintain the range of motion. We also want to elevate to reduce any swelling. We want to make sure that the elbow, when we're elevating the arm, is in a neutral position, not fully extended. You may want to consider placing some padding under the elbow to reduce pressure. The wrist and fingers should also be maintained in a neutral position. Prefab splints can help with that sometimes. Another concern with the fingers is we want to make sure that if they have burns on them, that we're wrapping each finger individually. If you don't wrap each finger individually, the burn skin on both fingers touching each other would then create or fuse together to create like a web-like structure. Scrotal swelling can occur, and we use a towel or a washcloth to slightly elevate the scrotum to help reduce some of that swelling. Lower extremity positioning. What you want to make sure you're doing here is to elevate them to reduce the swelling in the lower extremities. Making sure that you keep the knee in a neutral position, again, not fully extended. Worrying about the feet to prevent foot drop, and the heels so that they don't get pressure on those particular areas. Early mobility is a something that we want to make sure that we do as much as possible. It has several benefits to the burn patient. It improves cardiac output and venous return. Venous return will therefore decrease the amount of edema in the patient. It reduces the risk of pneumonia. It also has been proven to decrease the amount of delirium that the patients might have. By getting them up and moving them around, they get more used to their daily activities, and it also prevents deconditioning. It will preserve their muscle and bone density, and it helps maintain the circadian rhythm. Early mobility is early ambulation. You might also consider putting the patient up in the chair. Best practices have been made. Putting the patient up in the chair for every meal improves appetite and digestion. Active range of motion. If a patient's able to actively participate in their ADLs, let them, please, make them do as much as they can on their own. It is okay to move burned extremities. Any extremity that does not have a skin graft can have full range of motion up to the patient's tolerance. You might consider passive range of motion if the patient isn't able to participate or is unable to participate fully. For example, they move their arm, but they don't move their arm to the fullest extension because of pain or just self-restriction. We might encourage them by using passive range of motion to help them get to that furthest stretch that they can do. If you have any questions or problems, obviously reaching out to your PT and OT department, they definitely can help assist with plans and any kind of interventions that you might need help with. The last thing that you might consider is teaching the family and or significant others how they can help with early mobility and range of motion. Oftentimes the family members feel helpless at the bedside. This is an activity that they can help participate with, and then it allows you to do other things at that time. Range of motion. What we want to make sure is that we are giving the joints the best range of motion to prevent any deformity and preserve their function. The patients will need encouragement to do this, especially if they can't obtain full range of motion by themselves because of the pain. Pain medication might actually help to do range of motion a little bit more, so you may consider giving some pre-medication for these types of interventions. We want to do this at least 3 times a day, either active or passive range of motion, but obviously the more, the better the patient will have movement with. So in summary, optimal outcomes can be achieved with the proper positioning and early mobility of the burn patient. Edema control can help reduce pain, improve circulation, and then obviously reduce swelling to the extremity on average.